Hi, I am so elated to meet you in the program of 3 p.m. 3-point medics. We have been continuously learning the molecule of ARNI, angiotensin receptor neprilysin inhibitor. We are all aware that this molecule is extensively used in the management of chronic heart failure. Then apart from the indication of chronic heart failure, now it has been indicated in heart failure with preserved ejection fraction. There are few emerging reports which indicate that heart failure with preserved ejection indication may deserve administration of ARNI. Then apart from that, there are few RCTs clearly indicate that there is a possibility of administration of ARNI even in the case of cancer associated chemotherapy induced LV dysfunction. So apart from chronic heart failure with decreased ejection fraction, there are few more indications emerging that are favorable for ARNI. So what is ARNI? ARNI is angiotensin receptor and neprilysin inhibitor. So basically, as we discussed earlier, there are ongoing activation of two systems in heart failure. One is activation of RAS and another one is activation of brain natriuretic peptide. But here RAS system is detrimental to the heart, that should be blocked at any cost. Then another one, the natriuretic peptide system is much beneficial to the heart, that should be protected or the duration of action should be prolonged at any cost. But brain natriuretic peptide that is secreted from the dilated ventricles are very short-lived, in the sense as soon as it is produced from the ventricle myocyte, it is simply degraded by one molecule that is called neprilysin. That's why we have introduced neprilysin inhibitor, that is sacubitril. So sacubitril inhibits neprilysin, due to which the action of natural brain natriuretic peptide is prolonged. So this is the way it is beneficial. Then one may ask one question. So is it sufficient to just to promote natriuretic peptide system? Is there any necessity of blocking RAS system as well? Yes. There is simple trick and caveat behind this science. Please remember that neprilysin is a molecule. It not only deactivates our brain natriuretic peptide, it deactivates two other molecules as well. What are the other two molecules? One is angiotensin 2 and another one is bradykinin. So when you inhibit neprilysin with the help of administration of sacubitril, by which you are making more accumulation of natriuretic peptide. Yes, that is beneficial to our heart. Since neprilysin is inhibited, there is accumulation of angiotensin 2 and as well as bradykinin as well. As I told you earlier, the accumulation of angiotensin 2 causes intense vasoconstriction and it induces cardiac remodeling, which results in further LV dysfunction. That's the reason what happened when you administer neprilysin inhibitor alone, like sacubitril. What happened? There will be not only accumulation of brain natriuretic peptide, that is beneficial, there is accumulation of angiotensin 2 as well, that is detrimental. And one more molecule also is getting accumulated, that's called bradykinin. When bradykinin is accumulated, then you will have bronchospasm. So we have some kind of responsibility to block angiotensin 2 production during the time of neprilysin inhibitor administration. That's why we prefer angiotensin receptor blocker. Then somebody may ask, why angiotensin receptor blocker? Why can't you combine AC inhibitor with sacubitril? The reason is, when you add AC inhibitor, yes, angiotensin 2 accumulation will be inhibited. Yeah, that we should agree. But at the same time, when AC enzyme, angiotensin converting enzyme is inhibited, there is accumulation of bradykinin as well, because bradykinin is metabolized by angiotensin converting enzyme. So when you inhibit AC enzyme, angiotensin converting enzyme, it is not only the production of angiotensin 2 will be inhibited, there will be accumulation of bradykinin as well, which causes more bronchospasm. That's why we administer angiotensin receptor blocker instead of ACE inhibitor, which inhibits only production of angiotensin. It won't allow the accumulation of bradykinin. That's why we combine angiotensin receptor blocker, I mean valsartan, along with neprilysin inhibitor, that is sacubitril. So now you have understood that when you administer neprilysin inhibitor alone, there will be accumulation of angiotensin 2 and bradykinin as well. So angiotensin 2 causes detrimental to our body. That's why you have to add angiotensin receptor blocker, not ACE inhibitor. Now, there is one small entity called 36 hours washout period. What do you mean 36 hours washout period? For example, when you want to administer ARNI, angiotensin receptor neprilysin inhibitor, ARNI, but that patient who is already on ACE inhibitor, okay. So when these patients who are already on ACE inhibitor, when you add sacubitril, neprilysin, what happens? The sacubitril also causes bradykinin accumulation, even though it reduces the inhibition of natriuretic peptide. When you add sacubitril in those who are already on ACE inhibitor, what happens? There will be enormous bradykinin accumulation. Why? Those who are taking angiotensin 2 inhibitor will have accumulation of bradykinin, and when you add sacubitril, that will also cause accumulation of bradykinin. So what happens when you add sacubitril on top of ACE inhibitor? The more and more bradykinin accumulation will cause angioedema, which may be a life-threatening. That's why when you add sacubitril in those who are already on ACE inhibitor, what you have to do? First, you have to stop ACE inhibitor. Make sure that the accumulated bradykinin secondary to ACE inhibitor administration should be washed away. That will take minimum 36 hours. After 36 hours, we are ensured that there won't be any bradykinin in the serum. Then you add sacubitril. At the time, whatever bradykinin accumulation secondary to sacubitril, that will be taken care by combining your ARB. I think that you have to be very clearly mindful about this concept. So, whenever somebody is on ACE inhibitor, when you try to add ARNI, stop ACE inhibitor for 36 hours to make the way for washing out bradykinin accumulation, that is secondary to ACE inhibitor administration. Once bradykinin accumulation is cleared after 36 hours of drug-free period, then you add ARNI. So this is the concept. So now we have clearly understood that why you have to add angiotensin receptor blocker along with neprilysin inhibitor, and when you introduce ARNI, make sure that the patient is not on ACE inhibitor. If patient is on ACE inhibitor, after stopping ACE inhibitor, another 36 hours don't add ARNI, then add ARNI, then probably you can avoid bradykinin accumulation. Thank you.